That's yeah, I'm going the delirium and confusion in COVID patients, discuss delirium, of course, the COVID so, the case the 79 years old woman is hospitalized for treatment of COVID, infection. On day 2, the nurses report that she is confused, does not know where she is, and is not able to follow conversation or instruction. She is trying to get out of the bed. History include hypertension, diabetes mellitus, and osteoarthritis. There is no history of dementia or psychiatric illness. For this patient, which one of the following signs is diagnostic of delirium using the CAM criteria? So CAM criteria are the confusion assessment method. So A choice are A hallucination, B disorientation, C inattention, D agitation. So the question here, the case about hallucination, what is the major diagnostic sign or symptoms of the delirium? Because delirium patient can present with hallucination, they can be disoriented, they can have agitation, sundowning or inattention. So I don't think we can vote, right? So what do you think? What is your answer? Chat
agitation. Yeah, chat
Yeah, go just yeah, check it me out. Go just chat moderator check A how many and B how many?
B all
there are multiple choice for just one option, just pick one. Yeah, major criteria. What is the major criteria? The diagnostic. Question which one is the diagnostic of delirium? Right? So any hardware you can say this is delirium.
Now B C
So Dr. Josoye, how many A, how many B, how many C? Can you wrap it up?
B 5ခု6ခုလောက်ရှိတယ် C က2ခုလောက်ရှိမယ်ဟုတ်တယ်B က6ခုလောက်ရှိတယ် B ကဟုတ်တယ်
A ရော
A ဖြစ်တယ်မရှိ
ဘူး Okay, so the answer is yeah, the answer is C. ဒါမှမဟုတ်ဒီ question ဒီ case ရွေးတာဘယ်ဆိုတော့လူတွေတော်တော်များထင်တယ်အဲ့ confusion ပေါ့နော်အဓိက confusion နဲ့ inattention နဲ့ဘယ်ဟာကိုဒါ diagnostic ပဲလဲဆိုတော့ဒီ delirium မှာ the most important criteria is inattention. So disorientation or confusion that can be in patient with dementia. Patient already has underlying dementia or other neurocognitive diseases. So they can present, they can have a baseline confusion or baseline disorientation, but doesn't mean they have delirium. But on the other hand, patient with this, dementia or underlying neurocognitive or degenerative diseases, they can pay full attention. So one of the, most important criteria or, diagnostic, sign is inattention. So let's move on. So I'm going to go, more detail about. So delirium is also, it's also known as, delirium is also known as acute mental status change, altered mental status, acute confusional state, toxic or metabolic encephalopathy, right? So these are all, also known as. But now, general message, delirium, you need to spell out, it's a delirium. The acute, because they are not specific, acute mental status change, altered mental, this is a symptom, basically, altered mental, the patient presented with the altered mental status. But you cannot say that, exactly this is the delirium. So there's a criteria for delirium. So acute confusional state, it just say acute confusion, right? So what is delirium, right? So that's why the next slide, why delirium is important. right? Delirium, especially in COVID patients, delirium is associated with mortality in hospitalized older adults with COVID. So now think about it, a good say, you have a COVID positive patient who got, hospitalized or admitted, right? Actually, delirium on presentation, on admission delirium, or patient develop delirium during the hospitalization. There is a high mortality rate, so you need to pay attention. And don't wait until oxygen is dropping. So this is as important data. Actually, that very recent study, because there are more and more studies coming out. I mean, if you look at the odd ratio, is 2.39 with a very a reliable p-value. So the COVID patient, and the question is, why do they develop delirium? So as you know, COVID patient in general, there are so many, etiologies. So it can be from the respiratory failure, it can be from, the renal failure, or just a systemic inflammatory response, and all metabolic and endocrine disturbances. So acute, toxic encephalopathy, plus medication. Some of the medication we use, like even the dexamethasone, they can cause confusion, and so there are multiple etiologies. So again, now the COVID infection is thought to be associated with the increased risk of long-term cognitive decline in elderly population. So there are thought to be associated because we only have early data. Because COVID started basically in 2020, so we don't have a long-term study to validate that concept. But we do have a early data from some study showing that the COVID patient, even after recovery, they continue to have some kind of cognitive decline. Even the markers, the plasma, the CSF markers associated with the Alzheimer's disease. So yeah, it would be very interesting in long run. Those patients may develop dementia as a COVID-related dementia. So of course we need a data, we need a longer and bigger study to validate. But just a reminder that the delirium can have a long-term consequence. So let's talk about delirium itself. Okay, the slide here are not specific to COVID. It's just the delirium in general. Delirium is caused by general theory. I mean, a couple of theories. The delirium, the anti-cholinergic, through evidence of the cholinergic drug overdose, through the delirium line, and not general marginal 𝐵𝐴 the Benadryl, Benadryl, the anticholinergic drugs. Confusion and delirium. You can give a physostigmate because the cholinergic activity increases in the reverse visit. Through the one theory, acetylcholine, the activity decreased cholinergic activity goes through USARE. So the acetylcholine, important neurotransmitter for cognitive disease. So the dementia, Alzheimer's disease, they increases the choline, acetylcholine, level in the brain. So any drug which has an anticholinergic, the activity can cause, delirium. So especially overdose. Benadryl, you may overdose because the loan overdose. So unless there's a drug anticholinergic overdose, delirium the anticholine esterase inhibitor, the evidence on the shoe. They are not really helpful in treatment. So another marker is the inflammatory marker. Important in COVID infection. So now the studies have shown patient, the C-reactive protein. I think some hospitals they are monitoring the C-reactive protein. So there is a direct relation between increased C-reactive protein and the delirium, the incidence. So that's another correlation that the delirium is part of this inflammatory response, body inflammatory response. So C-reactive protein level, the delirium risk and incidence, or there is a correlation. The same thing with the interleukin-6. They are all inflammatory markers. So now the inflammation down below, the normal blood-brain barrier, disruption down below, the medication and the cytokines here, the CNS affected down below, the delirium, neuroinflammation may damage neurons, lead to the long-term. That's another reason, delirium can precipitate into long-term consequences such as dementia. I have seen patients mild stage of dementia, the delirium or that precipitate, or mild cognitive impairment. Once they develop delirium, that can precipitate into full-blown dementia. So because of that, the neuroinflammatory effect, and more cognitive decline down below. So let's dive into the definition. What is delirium? I said it's not it's not just a confusion. It's not just disorientation. So what is delirium? What can we call delirium? So definition is so acute patient has already a chronic confusion like dementia. So you cannot say delirium, right? So acute fluctuating, again, another hallmark is fluctuating mental disorder of impaired consciousness, alertness, and awareness with global impairment of cognition. So that's the this is the most very short and complete definition. Of course, the psychiatry DSM-5 criteria. Two criteria does a psychiatrist its own criteria. I like this very much. Delirium component. Disturbance, attention, and awareness. Dementia, they cannot pay attention. Dementia patient, they can follow you, they can pay full attention. The answer really off. Delirium, 35 years old engineer, COVID infection, they cannot pay attention. They keep shifting the subject. They cannot pay, they have a very short attention span. The attention and awareness disturbance. So disturbance develop over a short period of time, represent a change from baseline, tends to fluctuate during the course of the day. So another cognitive, disturbance. So memory deficit, disorientation, language, visual spatial ability, and perception. So the clinical criteria, the clinical presentation, number 1 and number 3 are the most important. Okay, duration and short period. Number 4, not pre-existing. Dementia or other neurocognitive disorder, underlying neurocognitive disorder, coma. Patient with the child metabolic coma, delirium, this is already a reduced because they already have a reduced level of arousal. The last one, this is the evidence from the history physical exam or lab finding that disturbance is caused by a medical condition. So best example is COVID infection, first case of all. Patient and the admission the positive cough a good confusion that is related to this infection. Or substance intoxication, about the Benadryl or the Barbitol overdose. And or alcohol withdrawal, or another medication, anticholinergic, medication side effects. So that criteria when not you can say delirium. Delirium that is not just a confusion. So let's dive into what is confusion then, right? So how is it related? So confusion just usually indicate a problem with the thinking. So in patient with any incoherent thinking, this is confusion, right? So confused patients are not able to think. So basically, this is a problem with the thinking. So confusion means this is abnormal, or incoherent thinking. That's it. So you cannot just diagnose everybody with delirium. Everybody who are confused with delirium. So confusion is, again, is typically associated with a depressed sensorium and reduced attention span. This is just a confusion. But this is the essential component, because without confusion, you cannot, on the other hand, you cannot really diagnose delirium. So that's why general topic was delirium and confusion in COVID patient. So confusion alone is not enough or adequate to diagnose delirium. So the confusion, okay, right? So the depressed sensorium or incoherent thinking plus reduced attention. So let me go back to the criteria. Look at it. The DSM-5 so number 1, disturbance in attention and awareness. Number 3 additional disturbance in cognition, right? So that's why the 1 and 3 are very important clinical criteria. But you need to have, it must, you need to additional information like, okay, that must be developed over a short period. It cannot be explained by underlying or existing or chronic neurocognitive disorder. And there must be evidence from history, physical, and lab finding that it is caused by a medical condition. That's why it is actually a delirium. So that's why confusion is not enough to diagnose delirium. So I want to differentiate between delirium and confusion. So any questions? So at this point, delirium and confusion. Any question? Okay, looks like everybody got it. So another concept. I want to send you a very strong message. Delirium, it should be considered as an acute brain failure. There's a new patient, new admission. Oh, there's an 85 years old with a history of CH and heart failure, came in with a heart failure. Everybody got alarmed. Oh, this is acute heart failure. This is acute renal failure. Everybody got serious about this acute renal failure, acute liver failure. But nobody paid attention to delirium or, but this is a very important concept. Delirium is acute brain failure. It is a final common pathway of multiple mechanisms similar to acute failure. The same concept, patient with dementia. It is also, you should consider them as a chronic brain failure. So actually it is worse than the heart failure, because as you know, heart failure, you can treat with medication, you can even transplant, right? It's the same with the kidney. You can go to India and you can have a kidney transplant. You can do a dialysis. The problem with the brain, you cannot dialyze the brain. You cannot get a brain transplant. So I just want to highlight how serious delirium is and how serious the dementia is, because the brain is so serious, so important. So don't mess up with the brain. Okay, let's talk about other information. So if you have a patient with delirium, there's a, they follow for 2 years. So in there, twice a chance of, death in 2 years period. 2 times the, risk of institutionalization. And 12.54 for new dementia. That's how it is serious. Persistent delirium, the poor long-term outcome, especially dementia. So if they don't recover, good news, the delirium can recover with a supportive care. But patient doesn't have a supportive care and doesn't have a good follow-up and good care, they can end up with dementia and long-term consequences. The problem with delirium are under recognition. Their data necessary recognize and document less than 50%. Physician we document because patient acute issues focus on it. We don't spend time. We don't pay attention to their mental fluctuation or mental state change. We don't engage in conversation. So we usually, miss the diagnosis of delirium. But on the other hand, diagnosing delirium is very, very important and very, very serious. On the other hand, diagnostic criteria, criteria, gold standard confusion assessment method. That's clinically very useful, more than 95% sensitivity and specificity. So let's dive into the confusion assessment method. So again, the Jones criteria, and the other criteria. So I want to say it's a 2 major and 1 minor, right? So what are the 2 major? 1 and 2 these are 2 major criteria. But you must have both criteria to diagnose delirium. Acute change in mental state. That's why patient with dementia or underlying degenerative disease, you cannot jump on to diagnose delirium. So acute change in mental status and fluctuating course. This is one major criteria. Another major inattention. That's why it's not just agitation or confusion. Number 3, so either one, not the 3 and 4 are either one, disorganized thinking and altered level of consciousness. So you just need one of those, 3 and 4 level. I don't think you're busy and you're making rounds, so you don't, so especially necessary they need to document. So I want to share the worksheet. So you can print it out. Print it out the patient chart make it. I like it because it's very easy. You just have to read the the line by line and just circle yes or no. Then at the end of the 2 pages, then you can say, oh, this patient has delirium because patient has both 2 major and 1 minor. So that make it easier to come again. It's a good habit during so the confusion assessment method should be done whenever there is a clinical suspicion of delirium, even routinely, like every 3 days, patient for all the inpatients, so that you will catch a delirium early on, especially hypoactive delirium. So is there evidence of acute change in mental status from the baseline? Yes or no? So yes, and there's one criteria. Or did the behavior fluctuate during the day? Inattention, right? Did the patient have difficulty so usually inattention usually you may miss it, right? So if you read it, being easily distractible or having difficulty keeping track of what was being said, so usually the nurses will pick it up. Oh yes, this is patient has inattention. So there you go, you have one more criteria. Disorganized thinking. Exactly, example was there irrelevant conversation, unclear or illogical flow of ideas, or unpredictable switching from subject to subject. Yes, he had his one, yesterday or this morning. Then you got one more criteria. The last one, level of consciousness. So you need to read. Is it hypervigilant, right? Vigilant or lethargic, or difficult to arouse? Yes or no? So then after that, you can get, you can finish the camp. So the problem is that camp, you need to print out, then you need that, there's a good substitution, especially digitally. I will share the link later on. So a brief confusion assessment that you can do it on the, your iPhone or your smartphone. There's a link, I will share it. So just look at all the 4 criteria, 1, 2, 3, 4, right? So the one by one, step by step, the app this year. So app a questionnaire to should be around the server will print out so you can use a brief 𝐵𝐶𝐾𝐬, they call a 𝐵𝐶𝐾𝐬 app that you can answer those questions. Patient mental status will answer yourself. Does the patient have altered mental status or fluctuating goal? No. Then we can negative, no delirium. So, but there's a yes. So you need to go to the inattention. Can you name so December to July backward right? So December, November, October, I hope you cannot really pay attention to them. Everybody, even with the basic education or the last and the last, next feature 3, alter level of consciousness. Now slide Richmond agitation, sedation scale. Yes, so doesn't positive delirium is confirmed because patient has 2 major and 1 minor criteria. So the feature 3 no the last one disorganized thinking. The question that very basic questioning. Patient with disorganized thinking, they can't get it right. They are thinking, or they will come up with a completely wrong answer, right? So this is a big, called a big gamble. Okay, time for another case. 53-year-old male with history of substance abuse had a motor vehicle accident and sustained body trauma and had multiple fracture along with traumatic brain injury and COVID positive. And patient was treated with dexamethasone and remdesivir for treatment. On day 8, patient started to have confusion, not able to recognize family. medications were, the enoxaparin, oxycodone, antacid, vitamin D2, and, senna, which is a laxative. Patient developed worsening agitation, cognition, and behavioral changes. Pasta, patient is yelling and screaming and not cooperating. So this is a full-blown delirium already. But family, patient is having problem recognizing some of the family via FaceTime and having difficulty with memory. So the question, what can be done to recognize delirium in the making? So can we detect delirium early on before they develop this full-blown hyperactive delirium, right? So this is a question. So the question is yes. So general delirium triage, the screening board, the delirium triage and screening test. DTS has 20-second assessment designed to rapidly rule out delirium. So again, this is to rule out delirium, right? So you can use it every day, very more frequent. So this is different between DTS and 𝐵𝐾𝐬, 𝐵𝐾𝐬 to diagnose it. This is to rule out, or 𝐵𝐾𝐬 to rule in, the DTS got to rule out. And also it's easy, 20 seconds. That's why, if you ask everyone to do a chem for every single patient every day, that's too much. Nobody will, be able to do it. Now, DTS negative, so yeah, you can document, root patient doesn't have delirium today. If positive, but doesn't mean patient has delirium. That's why you need to go through the, BCAM or CAM or, there are other tests to, confirm the diagnosis. So, data, the emergency department, data research, so DTS are 98% sensitive and 55% specific, one performed by non-physician and physician alike. Damlo, it's good to rule out, but not good to rule in. So what is DTS? The Richmond Agitation Sedation Scale. Let's look at the DTS, delirium triage screen, right? So the RAS, let's go back to RAS. RAS card the Richmond Agitation Sedation Scale, right? So the 0 are alert and calm. The patient is alert and calm, then you don't need to, that's why I want you to start with. So patient little restless, +1 restless, +2 agitated, +3 very agitated. So 0 and above get you a hyperactivity. That usually a hyperactive delirium. Because -0 is mildly drowsy, moderately drowsy, very drowsy, but even no responsive voice. So this is called, Richmond Agitation Sedation Scale. So, but it's easy, right? Because it's a 20-second. Patient is alert and calm. You don't need to, go up and down. So patient is alert and calm. Ask yourself. So alert and calm. This is, 0, right? So then next step again, the RAS score is not enough. So inattention. Can you spell the word lunch backwards? So English lunch backwards. English no matter the number net the best thing backward English 21854. Can you say it backward? So 0 or 1 error, so DTS negative. But to be positive, then you need more than 1 error, right? So LU at the lunch mark, LU and C, backwards HC and LU. Well, that's still sorry. Oh, that's a two value. So I'm more than 1 error. So positive. So you need to go ahead with the PCAM. Next slide, the QR code the smartphone. I want you to pull your smartphone and use your camera to go to the link, because link if you have to type in it, you won't have enough time, or you may not have time to do this. But slide share if you have your smartphone with you, why don't you use a QR code reader, and if you have an iPhone, you can use your camera, and then a link you can save as a add to home page. So the website go iPhone add to home screen. So add icon save round app tap website ကိုရောက်သွားတယ်အဲ့မှာသူက flow လေးနဲ့ So I might about your lesson. Well, one at time, DTS ma the RASCO ma, 0 or not. 0 so ma next, zeros in the negative. 0 mama to other bit so in next step, the step by step in the Dora, the calculator about don't jealous or the best rounding. You don't need any paper. You can just, use the app and go through that step by step, and you can rule out and you can rule in, once it is positive. So QR code or the GTS calculator, output QR code or BCAM calculator. So of course, the cam, the to rule in or 3D cam, the chart is a sheet. The recommendation of BCAM, the brief cam or I think general recommendation. BCAM or the QR code, save it in your smartphone, no? So the hyperactive delirium patients type is down general IV line is yelling and screaming, a little too late. The medicated PMS a little too late. Important to recognize the hypoactive, which is more than 50% of the cases. The men usually are less recognized because patient now so we are picture we are give side down. They are pleasantly confused. They are pleasantly confused. But one point, to be a little too late. So not good enough pilot general the sundowning. The sundowning the restless fit arrow down general. The sundowning is not diagnostic of delirium. So the general change sundowning is a diagnostic. No, sundowning can happen with dementia. Sundowning can happen with depression. So sundowning doesn't mean nothing, anything with the in diagnosing the delirium. What are the risk factors?
Hypoactive delirium, it's all the hypoactive delirium. Can they lead into the hyperactive delirium, or they just stay for the causes hypoactive delirium?
They can stay, hypoactive for the whole causes. Yeah, they don't have to develop hyperactive during the hospital stay. So that's another risk, no? The patient confused. Family everything is stable, so decelerated. Patient may still go home with a hypoactive delirium, but the consequences are the same. They may have long-term consequences. So yeah, but on the other hand, mixed delirium amiable. Usually they present with the hypoactive, and all of a sudden they develop hyperactive.
Yeah, I'm sure I'm come across a lot of hypoactive delirium I might have missed.
Right, right. So that's why the very important to use a GTS, that is triage screening, or especially necessary that also can don't I so not the best one, no?
My audience said delirium
Yeah, so delirium Davidson the Macaloma delirium so yeah that be
delirium solution
right. We don't really diagnose that. That's why there is no even no translation looks like it. Yeah. Right. Yeah, 𝐤𝐞𝐜𝐿 roughly diameter. Yeah, I think so. So yeah, let's go move on. Predisposing factors are advanced age. That's the cognitive reserve through multiple other factors, through the underlying diseases, poor kidney function. So area the lung reserve, underlying dementia itself as a risk for delirium too. Highlight functional impairment. This is very important. They don't have to be all age patients who are the functional impairment itself is a high risk for delirium. medical comorbidity ကျွန်တော်ပြောလို့ပေါ့ပြဿနာကြီးတော့ဒီအခြားယောဂတွေများရှိတဲ့လူတွေကပို့ပြီးတော့ delirium ဖြစ်ဖို့ chance များတယ် history of alcohol abuse very important alcohol က usually ဒါမှမဟုတ်alcohol chronic alcohol abuse they are prone to develop delirium also they are prone to develop dementia so alcoholic dementia is the known etiology of one of the causes of dementia for some reason ဒါကတော့ကျွန်တော် scientifically မရှိနိုင် male sex တွေကပို့ပြီးတော့ delirium ပို့ဖြစ်နိုင်တယ် sensory impairment ဒါမှမဟုတ်ဒီဥပမာအခြေအနေမှာအရင်ကြီးကြည့်တာညမှန်တက်တဲ့လူတွေကိုညမှန်ရဖို့အရေးကြီးတယ်သူတို့အိမ်ကနေခေါ်လာပြီးတော့ညမှန်ပါမလာဘူးတို့ဒီ hearing aid ပါမလာဘူးဆိုရင်ဒါတွေက delirium ဖြစ်ဖို့ပို့ပြီးတော့ chance များတယ်ဒါမှမဟုတ်ဒါတွေကကျွန်တော်ဒီ one part of the admission ကသူတို့ညမှန်3လားဒီ hearing aid 3လားရှိရင်တော့အဲ့ဒါချက်ချင်းယူလာပိုင်းမှာဒါတွေကအရေးကြီးတယ်precipitating factor right ကျွန်တော်ဒီကနေ့ပြောရတာ predisposing now precipitating factor ဆိုတော့ဒါမှမဟုတ်ကျွန်တော် infection နဲ့အသက်ကြီးတွေမှာသူတို့ဒီ infection ကျွန်တော် covid infection ရပြီးတော့ကျွန်တော်ဒီ confusion ဖြစ်တယ် UTI ကျွန်တော်ဒီ UTI နဲ့ pneumonia နဲ့ကျွန်တော် delirium ဖြစ်တယ်စီ acute infection ဖြစ်တယ် acute cardiac event ဒါမှမဟုတ်ဒီ heart attack နဲ့ရတာရှင်းနိုင်တယ်ကျွန်တော်ဒီ pneumonia prolonged bed rest is another risk drug withdrawal so another thing ကကျွန်တော်ဒီ လူငယ်တွေ middle age မှာဆိုသူတို့အိမ်မှာညနေဘက် twin စားရင်အကျဉ်းနဲ့တောင်းနေကြတယ်ဦးစေးမှာ covid နဲ့ရှင်းရောက်လာတယ်သူတို့ရပ်ဆက်တောက်လို့မရတော့ဘူးအဲ့ချိန်မှာသူတို့ withdrawal အနေနဲ့သူတို့ delirium လည်းရနိုင်တယ်ဆိုတော့အဲ့ဒါလည်း important part of the history taking နောက်တစ်ခါ fecal infection ကျွန်တော်ဒီမှာ usually ကမမေးကြဘူးဒါတွေကညွန်စရာကြီးကျွန်တော်တော့ရေးမကြည့်ပါဘူးဒါပေမဲ့ဒီ constipation and fecal infection is a risk factor for delirium too fluid and electrolyte disturbance ဒီ catheter တွေပေါ့နော်ဒီ urinary catheter တို့ pulmonary catheter တို့ဒီ nasogastric tube တွေကလည်း it is a risk factor for delirium medication another slide မှာကျွန်တော်သွားမယ် restraint anemia uncontrolled pain ဒါမှမဟုတ်ကျွန်တော်ဒီ post op patient တွေမှာပေါ့နော်ဒီ surgery patient တွေ post op patient တွေမှာဒီ pain ကို control မလုပ်ပြန်ရင်လည်း is a ဒါမှမဟုတ်pain ဒီမှာတော့ morphine ရရင်တော့ strong pain medication ရရင်တော့ you need to control the pain even though the opioids တွေပေါ့ဒီ morphine တို့ဟာမျိုးတွေက yeah it's a risk for the delirium but uncontrolled pain is for sure is a risk factor for delirium so you have to pick the battle which battle you're going to fight so uncontrolled pain is very important especially in post op you need to control the pain otherwise they will develop delirium which is again already it will be worse because patient now has uncontrolled pain and delirium this is a nightmare so urinary retention so make sure see theပုံမှန်သွားနိုင်ရလားစီကတော့စီးသွားတာ8နာရီနဲ့10နာရီလောက်ရှိပြီဆိုအဲ့ချိန်မှာ maybe ကျွန်တော်တို့ catheter ထည့်ပြီးတော့ကျွန်တော်တို့တက်မလားဒီ residual urine ကိုကျွန်တော် measure လုပ်ရလိမ့်မယ်ဘာဖြစ်လို့လဲဆိုတော့ now what are the risks so delirium is you can predict actually caused by the sum of the predisposing and precipitating so a patient have more predisposing factor they just need a one precipitating factor so let's go back so now you have a patient patient is 85 years old with underlying dementia so all they need is what again the viral infection even with a viral infection they can develop delirium even with a dehydration they can develop delirium so that's why delirium is caused by the sum of the predisposing and precipitating factor of course young patient ကျွန်တော်တို့ဆေးရုံမှာတွေ့ရတယ် covid positive အသက်40ပဲရှိသေးတယ်ဒါမဲ့ဘယ်လို patient acute renal shutdown ဖြစ်နေပြီဆေးတွေသုံးတယ်ဒါဖြစ်တဲ့အခါကျတော့ yeah they have multiple precipitating factors they will develop delirium for sure so what are the so that thanks to Dr. Mamonte သူကတော့ကျွန်တော် mnemonics နဲ့မှားလွယ်အောင်ဆိုပြီးတော့ delirium လေးသူက share လုပ်ထားပါတယ်ဆိုတော့ D for drug E for electrolyte imbalance lack of drug withdrawal infection reduced sensory input intracranial disorders U for urinary and fecal disorder like constipation urinary retention and for myocardial and pulmonary disorder so the mnemonics are predisposing and precipitating factor common ဟာတွေပေါ့အကုန်လုံးတော့မပါဘူးပေါ့နော်ဒီ common ဟာတွေကိုကိုယ့်ကိုပြန်ပြီးတော့ screen လုပ်ချင်တယ်ဆိုရင်ဒီ delirium mnemonics ကိုပြန်ပြီးတော့သုံးလို့ရပါတယ် okay ကျွန်တော်တို့ evaluate လုပ်မယ်ဆိုရင် number 1က history and physical again back to the basis သူတို့ underlying history မှာ risk factor တွေပါရှိတယ် physical exam မှာပါတဲ့ signs ofပေါ့heart disease other abnormality including the urinary retention. Urinary retention, you don't need to, put a catheter. You blood the suprapubic fullness and suprapubic tenderness that you can, this is the time you need to, you can confirm with the catheterization, but you don't need to just put a, urinary catheter every time you want to rule out, urinary retention. So urine analysis, in fact, urinary infection rule out, urine toxicology, the metabolic, the drugs, the toxic materials, the liver function, liver disease, so drug level patient with the toxicity, the toxicity, they can present with the delirium too. Arterial blood gas, chest X-ray. So good thing I read the highlight about it. So CAT scan, the cerebral imaging are not usually not helpful. Only patient had a head trauma or neurological focal neurological finding, then you should consider you should do a CAT scan. Otherwise, don't do the CAT scan for every single patient. EEG and CSF are the same thing. Yeah, patient with signs of meningitis. Yeah, cardiac signs of the strict reaction test or positive fit or suspect fit or the lumbar spinal tap or something. You don't, even in the elderly, you don't need to do it as a part of the delirium workup. So there's a multidisciplinary for it. When the necessary alcohol front line, they spend more time with the patient. They can report back to you about their inattention and disorganized thinking. We've got family members. Yeah, they can tell you, they know their baseline. They will tell you, that's not his baseline. So multifactorial approach is most successful because multiple factors are, involved. So, failure to diagnose and manage, can be very costly because, the prolonged length of stay to start with. So how do we manage? So, we're going to talk about medication, about treat the infection, pain, fluid, make sure that they are eating and drinking, and behavioral control, behavioral and pharmacological intervention. So anticipate and prevent complication, to change the position, sleep, and restore function. So during a patient, lunch out there, lunch out to family, physical therapist, and delirious fellows. So we are, don't keep them on the bed all the time. So Daria, you say the delirium or alcohol, antibiotics, some antibiotics, anticholinergic, anticonvulsant, antidepressant, antihistamine, the Parkinson's disease. The treatment cinemaga, patient with Parkinson's cinema, maybe delirium, you may want to cut down the dosage because cinema itself is a risk for delirium. So antipsychotic, phenobarbital, benzodiazepines, even the H2 blockers, they can precipitate delirium. So, of course, they are taking it for a long period. They may not, may not be the immediate, cause for it. I mean, they are risk for delirium too. So how do you manage? So again, orientation EEG, reminder, so reminder is important. So socialization. So family will, let them see the family because again, they are seeing different nurses, different physicians, different time. That can make them more confused. So family members are very familiar, they are more reassured and they are more comfortable. So I'm gonna make sure eyeglasses and hearing aids are appropriate. Mobilize the patient. Of course, make sure they don't fall. The family member, physical therapist, and let them move around. Adequate intake and nutrition. The best thing is the hand feeding. So don't think about tube feeding because that can make delirium worse and they may pull it out. That's another nightmare, so more trauma, more agitation. Educate and support the patient and family. So another concept, social restraint. Social, family member, losing or sit up for losing or trying so they will feel a little bit embarrassed or they don't feel safe. Family member, one family member, they say COVID, we don't need multiple family members. So family member, they can come with a shift. avoid physical or pharmacological restraint if possible. Okay, let's do another case. 80-year-old were admitted to the hospital because of worsening agitation that began a few days ago. COVID tests were positive about 1 week ago. So moderate Parkinson's disease, patient refused their physical exam, now be delirium chinity. So UTI here. So patient is trying to leave and cannot be redirected. Family is at the bedside. 1 a.m. in early morning, agitation was and patient tried to hit the nursing center. Now patient is being physical. She has been receiving the routine medication. So which of the following should be started to lessen the patient agitation? Now patient are physicalဖြစ်လာတော့ nothing will like your two hit long maybe that we have now this is a time to give the medication. The medication was also medication the confusion itself next thing the medication confusion itself they don't do nothing. So the confusion itself do not use medication. The only indication for delirium is that physical agitation. Now removing the IV fluid, removing the tubes, remove the you need a medication. So what is your answer? So you do not check you have monitor how many choose A, how many choose B, how many choose C, and how many of choose D. Please type it in the chat. Yeah, that's fine. Let's discuss. There's no right or actually. The good news that FDA didn't approve any of those medications. It's all off-label. That means a recommendation on organization in academic institution out there. We have a recommendation. We didn't go over the recommendation.
အဖြေကတော့အစုံပဲဟိုမှာ A က2ယောက်လောက်ရှိတယ် B က1ယောက်လောက်ရှိတယ် C က1ယောက်ရှိတယ် B က2ယောက်3ယောက်ရှိတယ်အဖြေကတော့ it's all over the
Okay, that's good. I like that. Yeah, let's look at the answer. Okay, so if absolutely necessary, right? Absolutely necessary. Like remember physical agitation, removing the tubes, spitting out the medication, right? Patient this is the time for medication. So what is the drug of choice? High potency antipsychotics such as haloperidol. Again, it's an off-label, but again, generally the organization, academic institution organization recommend if you must use a medication, use the Haldol in low dose because Haldol, as you know, is a non-sedative and is also very effective to control the physical agitation, especially the ICU setting, ICU ventilator in the tubes in the IV fluid in the chamber. Haldol effective treatment was a post the patient that's general type IV control agitation. The recommendation is use Haldol low dose. That's the best way to calm the patient. The Haldol should not be used to patient with Parkinson's disease, Lewy body dementia, or his history of neuroleptic malignant syndrome because as you know, Haldol it has the most extra side effects. So I'm going to Haldol the Parkinson's disease patient Haldol zone the malignant neuroleptic malignant syndrome. Again, neuroleptic malignant syndrome just to refresh. Patient present with a fever and rhabdomyolysis and acute renal failure. So that can be fatal. So the lawsuit option. Yeah, patient with any doubt, any history of Parkinson's disease or Lewy body dementia, go ahead and use the quetiapine or olanzapine. Try to avoid the haloperidol. But if your patient doesn't have any of those history, no Parkinson's disease, no history of Lewy body dementia or Parkinson's disease dementia, but especially in the ICU setting, patients on the IV line and tubes, go ahead and use a Haldol. So next I got another what about again Haldol quetiapine risperidol another atypical antipsychotic olanzapine Zyprexa because this Zypresidol Geodon another brand name Geodon. So aripiprazole, which is called Abilify, brand name Abilify so we learn it. Melatonin so another problem the choice of the option. One take home message about this or the QT QTC ပေါ့နော် QT ကတော့ EKG သုံးရမယ်ဆို QT prolongation is very important QTC ပေါ့ဒီမှာတော့ဒီ QTC because all the medication can cause a QTC prolongation because as you know QTC prolongation patient already prolonged QTC ပေါ့နော်အထူးဖြင့် more than 500 generally speaking more than 500 millisecond QTC ဖြစ်နေပြီဆိုရင်ကျွန်တော်ဒီအဲ့ဆေးတွေသွားသုံးနေဆိုရင်ဘာဖြစ်လဲဆိုတော့ဒီ quarter pain တို့ဒီ geodon တို့သုံးတဲ့ခါကျရင်QTC prolongation နဲ့ကျွန်တော်ပြော toss up the points that ventricular arrhythmia ရနိုင်တယ်ဆိုတော့အဲ့တော့ QTC prolongation မှာဆိုရင် the drug of choice QTC prolongation ပြီးမှာ drug of choice ဆိုတာ Haldol, Risperdal, Olanzapine and Abilify these are the drug of choice patient with a prolonged QT ပေါ့နော်ဆိုတော့ prolonged QT မရှိဘူးဆိုတော့ doesn't matter quarter pain ပေးလို့ရတယ် Risperidone ပေးOlanzapine နဲ့sorry အဲ့ဒီကြိုက်တာပေးလို့ရတယ်ဒီ Depakote valproic acid ကတော့ငါပြောအဓိက liver ထိတာမလို့ patient with underlying liver disease ဆိုဒီစာတို့ကတော့အဲ့ဒါရှောင်တဲ့တယ် Depakote ကတော့ဆိုတော့ melatonin ကတော့သိပြီးတော့မထိရပါဘူးသူက sleep ပေါ့လေ sleep က safe ဖြစ်တယ်ညဘက်အိပ်လို့မရဘူးဆိုတော့ melatonin ကတော့ very safe okay the last case we should wrap it up the average length of stay in your hospital medical unit has been increasing analysis of outliers among the most common diagnosis related group reveals the number of patients who have prolonged hospitalization secondary to acute confusional state so as a member of the quality improvement committee you have been asked to suggest evidence-based measures to prevent this problem. So, say delirium ကြောင့်မလိုအပ်ဘဲနဲ့ဆေးရုံအကြာကြီးတင်တဲ့လူတွေဘယ်လိုဆေးရုံဒီ administration နေနဲ့ဘယ်လို reduce လုပ်နေပါတော့ What are the following interventions you should recommend? Number 1, train the nursing staff to perform the serial mini-mental state exam. Establish a delirium consultation service to evaluate patients at the request of the attending physician. Implement a clinical pathway to expedite neurologic imaging and other diagnostic tests. Establish interdisciplinary protocol to address sensory impairment, immobility, dehydration, cognitive impairment, and sleep deprivation. Implement early discharge planning so the patient can be sent home before the predicted length of stay is exceeded. So let's vote again. What is your answer? So it's
D A and Nakushi now D. Now it sounds like D to me.
Good. So the answer the best management you got try to send you that take home message. The best management for delirium is prevention. The Wesley Hospital you need to have an intervention or for every high risk patient or every patient cognitive intervention for cognitive impairment, sleep deprivation, immobility, sensory impairment, and dehydration. So they only target those 5 things focus on non-pharmacologic approach. So a sleep protocol involving the warm milk, back rubs, and soothing music. Limit or avoid psychoactive and other high-risk medication. So I model Yale website the Yale website HELP health program Yale University ရေးလိုက်ရင်ဒီမှာထွက်လာနေတယ်အဲ့ Yale ကဒီ study ကတော့ကျွန်တော်အောက်မှာပြောတာဒါ New England Journal မှာthat's a one of a kind study published in 1999 that study showed that that intervention decreased the incidence of delirium. So evidence based evidence-based the intervention ဒါပေမဲ့ဆေးရုံမှာဘယ်လိုဆေးရုံကဘယ်လိုသုံးလဲဆိုသိကြရင်ဒီ Yale University မှာHELP hospitalized elderly program HELP L က adult life I think hospitalized adult life program HELP health program ဆိုမှာဒီမှာတော့ရဲ့ protocol တွေshare လုပ်ထားတယ် So I think that's my last slide. So this is I'm open. Now I like to open for any question or any discussion.
တချို့တွေအခုကျွန်တော်တခုတွေ့တာလေတချို့ဆေးရုံမှာလူနာတွေကိုအဲ့လိုမျိုးလေအပြင်က nurse 8တယောက်နဲ့အပြင်ခေါ်ထုတ်ပြီးတော့အဲ့လိုပန်းညံနဲ့သွားထိုင်တာတို့ဘာတို့နောက်တစ်ခုဆေးရုံအသစ်တွေမှာဆိုတချို့တွေ့တာကြတော့အဲ့လိုပေါ့အခန်းထဲမှာဗလဲမောက်ရှိတာတို့ဘာတို့ဒါမျိုး activity တွေရော delirium တကယ်ချပေးတာမသိဘူး
Yeah so anything is better than ဟုတ်လေဒီမဲ့များသောအားဖြင့်ကျွန်တော်ကျွန်တော်တို့အဓိကရှောင်သင့်တာတော့ဆေးရုံမှာ grade 1မှာပဲတစ်ချိန်လုံးနေခိုင်းပြီးတော့ you know, Cholema Chalu, so we're going on in the same time and the channel. Yeah, Damlo. Good thing, in truck kind of the outside man, you know, exposure, you know, the weather, and that's a reminder that they live in the community and this is where they are. As long as there is someone who can through a family member, a family member, because that's a mobilization through the natural day, you know, need sunlight, vitamin D. So yes, you know, so it's not everything, and anything is better than, you know, keeping them on the bed all the time. It's still so in here. I'm going to just show them, you know, matana, general, diesel, regular beer, to me, so that country, no, even to me, country, I'm a done green beam, green one, tribute of Amadi, which animal, no, who chair one time, you know, to me, it's better because delirium patient, they also risk for, you know, aspiration. So, you know, at least, you know, sitting, you know, for me is better than, you know, having them eat on the bed.
Okay, so Jesus Timare, do meta the geriatric medicine, delirium good, Kulu, Shinpiare people, no? The delirium is, I think, more than common as we think. Or not to know, Tina Tech, common Pidelos, no, Tine, to know, say, Male, the delirium case are really, Kanana, Chung, 2 years, no? That Luna, the Babio, the swan look down, not the Kuku Piana, Bama, Namo, when a 2 needs no near Salaria. It is a common encounter, no? To know, say, Male. Kudu, general. Like Charlie or Puro, we can give more attention to those patients. That's the coup. Now the coup and delirium and the Oniro, Pipia, the coup, general Seuma, Duaro, the head injury, Duaro, no Lunga, Diva. Head in the Yabro, general at all the Kona, Saruaro, to consist of the orientation, the personal time and space, Akono, the Akono Yare. The Nian is zero to so no say one when I come cut have gay lenias and pay her. So no says Rivia to me. And the gay go Jovirama, appearing with Tretor. Appearing Tretor, the truth or the dual letter of Mativu to go. They maintaining talents on Matiro. So Lasha. Pitu Yago the time to run at Stan and Lokuni, to run a Lanzamaya. Then suddenly, it's a phone call. And the Meroluna de my young no? Labro Yuva, rent some money to town. Town a miracle, General Topio, a Muriale, payment, the my with money net, well, we are Biroma, the 4 wage Diane, General Seongani Biro, the Shin my love, where is Shin my go my love, where in Yama. Luna, Erema Yawni, Erigani to Pianlara, to Pianlara, Erinia through you are. Pian Labro, Seun the Cap, Pian Labro, Seuma, Pian 80. Pian Roger, now time, the Lauchero, to go discharge no pian no lady. So, the Haga, to go pian mirror let to Ale, Bama, Mapioro, to go bedua pane below look this, Bama, Melumiaro. And I'm Mujero. Thank you.
Yeah, so delirium, you know, I think this is, you know, the hypoactive delirium, you look at the patient or the material, the hypo delirium, they also wanted to go home. Just be a family member, and now I'm the environment, you must say, they decided, I want to get out. I don't want to stay. So I just that's how general they just got out, you know. So they decided to do this one. No? So the hypoactive delirium also very important to detect so that they can they can develop hypoactive delirium or they can elope all of a sudden. So this is a patient with a hypoactive delirium. They just decided to get out because they don't feel safe or they don't feel comfortable in the hospital. So treatment in there I'm a patient in general the health or general patient but they just wanted to get out. So account of the sale must never assumption machineနောက်တစ်ခုကတော့ဒီမှာတော့ဘာလို့ရမလဲမသိနော်ဒီတက်နိုင်တော့ဒီ GPS tracker နဲ့ပေါ့နော်တကယ်လို့ even ပျောက်သွားရင်တော့of course if you can't have a ဒီအဘွားမှာအဆောင်မထားနိုင်ဘူးဆိုတော့ပျောက်သွားရင်တော့အနည်းဆုံး locate လို့ရမှာပေါ့နော်ဒီမှာဆိုတော့ GPS tracker ပဲနဲ့ကျွန်တော်တို့သုံးလို့ရတာပေါ့ဒါပေမဲ့အဲ့မျိုးကြတော့ကျွန်တော်တို့ကပြဿနာဒီ သူတို့ကစိတ်ကူးပေါက်တဲ့မှာသူတို့ကထွက်သွားမှာပေါ့ဒါပေမဲ့တို့ဒီ physically aggression မဖြစ်ဘူးဆိုရင်တော့ there is no indication for medication unless the only medication are the physically agitation or try to remove the tubes and spit out medication. Yeah, you can get delirium. I mean, hypoxic delirium, they just decided to get out so very difficult to control. I know advice either family member is around most of the time. To see staffing and so you have no choice to put a guard on the main hospital main building the nowadays sit on payment trouble alert the nurses and
okay system ရကျွန်တော်ဒီမှာတော့ဒီ start မလုံးတော့သူတို့အမျိုးတွေကအနည်းဆုံးလူနာဆောင်တယောက်သူတို့အမျိုးတွေကလူနာဆောင်ဖြစ်သွားတာပေါ့နော်အိတ်ကြတချို့ဆိုရင်2ယောက်ထိတော့ကျွန်တော်အိတ်ခွင့်ပြုတယ်အဲ့ဒါလူနာတယောက်ရှိရင်ကျွန်တော်ဆေးရုံရဲ့ဒီလူကြီးကတော့လူနာနဲ့ဆို3ယောက်လောက်ဖြစ်သွားတာပေါ့နော်အဲ့တော့သူအဆောင်ကလည်းမတိလိုက်ရှာဘူးသူအိပ်ပျော်တော့ခိုးပြီးတော့ထွက်တယ်ဆိုတော့
right
thank you
နောက်တစ်ခုကဒီခုစဉ်းစားလို့ရတာပေါ့နော်ဒီအမေကအဆောင်ပေါ့တညလုံးအဆောင်ထားဖို့ဆိုတော့လည်းလူကလည်းမရှိဘူးပြီးတော့ပတ်စံပြီးတော့နောက်တစ်ခုလို့ရတာဒီ video camera ပေါ့နော်ဒီ nurse တွေပဲဒီ nursing station မှာဖြစ်ဖြစ်ဒီအဝမှာဒီvideo camera နဲ့ monitor လုပ်ပြီးသူတွေဝင်ထွက်ကိုတစ်ချက်ချက်ကြည့်ပေးရင်တော့မစိုးဘူးပေါ့ဒီ risk patient ဥပမာဒီ patient ဆိုရင်ဒီ video camera ရှိတယ်နောက်လည်းကျသူ့အိမ်မှာတွေ့တာနဲ့ဟိုမှာထွက်ဖို့ကြိုးစားနေပြန်ပြီ so you can catch him before he does it again ဘာသာလို့အဲ့တခြားဝေးရောက်သွားမှဆိုငါဘယ်လိုပတ်စံလဲကုန်ပြီးတော့နောက်တစ်ခုနောက်ခေါက်ပြန်လိုက်ရတယ် plus he can get hit on kidnap or get killed ဆိုတော့ maybe another option ကကျွန်တော်ဒီ video camera နဲ့အဝမှာပဲကျွန်တော် monitor လုပ်ထားဖို့เนาะဒီအားလို့ဆိုပြီးတော့
thank you sir
ဟုတ်ကဲ့ဆရာတခုလောက်မေးလို့ရမလားမသိဘူး
ဟုတ်ကဲ့ပြောပါ
ဟုတ်ဒီလိုမျိုး delirium ဖြစ်တဲ့ patient တွေ covid ကလည်း positive ပေါ့နော်ဆရာအဲ့လိုမျိုးလူနာတွေကြတော့သူရဲ့ treatment ကိုမြန်တီးတန့်ပေါ့နော် adjust လုပ်ရတာမျိုးတွေရှိပါသလားဘာလို့လဲဆိုတော့ antihistamine တွေပါပေးလို့ရှိရင်လည်းသူကdelirium မှာမပေးလို့အဆင်မပြေဘူးလို့ဆရာပြောသွားလို့ပါ
okay so treatment တွေနဲ့ကတော့ဒီ of course the covid patient တော့တခြား covid specific treatment remdesivir တော့ပေးရမှာပဲဒီဘောကဒါပေမဲ့သူ့မှာထားမယ်ဒီမှာ DEXA ကျွန်တော်တခုပြောချင် DEXA ပေါ့နော် DEXA တော့ဒီ oxygen saturate ဒီ hypoxia မရှိဘဲနဲ့တော့just do not give DEXA routinely သူပြင်အသက်ကြီးတဲ့လူတွေ high risk for delirium ဘယ်လို patient တွေမှာဆိုတော့အသက်85နှစ် patient တွေကိုရတဲ့ dementia လေးဖြစ်ချင်တဲ့ multiple medical reason now patient got admitted as long as the oxygen saturation not dropping from the baseline as long as oxygen saturation is more than 93% show you a baseline oxygen that admission 95% oxygen saturation as long as they can maintain the oxygen saturation you don't just start a dexamethasone မလို့ပဲနဲ့ဒီ antihistamine ကတော့ကျွန်တော်တို့မှာသုံးမတော့တတ်နိုင်တော့ရှောင်တဲ့ antihistamine ကတော့ဘယ်တခြားဆေးတွေသုံးရမယ်ဆိုရင်လည်းဒီ antihistamine ကတော့ high risk of delirium ဆိုတော့အဲ့လိုမျိုးတော့လုံးဝရှောင်တဲ့နောက်တစ်ခုကဒီမလိုအပ်တဲ့ဆေးတွေပေါ့နော်အထူးသဖြင့်လို့ရတာဆေးရုံမှာကျွန်တော် mission မှာမလိုအပ်တဲ့ဆေးတွေ review လုပ်ပြီးတော့သူပြင်မှာဒီ H2 blockers တွေပေါ့okay ဒီ SI မှာဒီ acid reflux နဲ့တောက်ထားဆိုရင်လောလောဆယ် acid reflux မရှိဘူးဆိုရင် you can stop it ပြီးတယ်မလားဆိုတော့သူပြင်I'm sorry အမျိုးတွေပေါ့မလိုအပ်တဲ့ဆေးတွေကို you can stop it ပေါ့ဟာလေဆိုတော့ဒီ antihistamine ကိုတော့တတ်နိုင်ရင်တော့ဆေးရုံမှာလုံးဝတော့ကျွန်တော်တို့မသုံးသင့်ဘူးပေါ့နော်အဲ့ဒါတခုပြောချင်တာပေါ့ဒီ morphine ပေါ့နော် morphine ကတော့တခုရှိတာပေါ့ဒီလို morphine ကတော့ဒီ covid နဲ့ respiratory distress နဲ့ဥစားဖြစ်နေတယ်ဆိုရင်တော့အထူးဖြင့် palliative care အနေနဲ့ကျွန်တော် tomorrow I will discuss more about morphine အဲ့လိုကြတော့ you have to use it ပေါ့နော်so morphine itself can cause delirium but there's a benefit versus risk so it's all about medication and all about benefit versus risk. The Valium, the benzodiazepine, we use it in palliative care sometimes, right? So of course, because if there is a more benefit than the risk or the side effect, then you can use it. But if there is a risk more than the benefit, then we should try to avoid it.
Yes, the cool of mentioning. Oh, the COVID, the delirium, H group, shape, below shape, common
Yeah, this is a very easy question, but it's all across the board. COVID, data research triage, the same data really. That the delirium risk, not just COVID infection, any hospitalized patient risk, delirium risk that. The age is the main factor. The child factor is not the multiple medical condition, plus C-reactive protein level. That's another relation about the delirium risk. The age alone just old age itself is a risk for delirium.
Okay, just make let's call it Mashiro solution conclude Luyanova.
Jesus Timare.
Okay, palliative care in terminally, a patient
Okay,
You're welcome.
Bye bye.